Good morning everyone, this is Dr. Saran Reddy live through Facebook from ADR Plexus Studio. Today being our National Sports Day, I wish all of you reach your goals with the very same ease how Johnson used it to convert his goals. Now I am going to discuss 4 important things, that is importance of anesthesia and intensive care for postgraduate medical entrance examination, the important topics list in the recent exams, and potential topics for the upcoming exams and the recent updates. While we discuss all these things over the next 25 to 30 minutes, I request all of you to keep all of your doubts in the comment section so that after completing the session, I keep on answering those questions. First, coming to the importance of anesthesia intensive care for postgraduate medical entrance examination, if we divide it into 3 categories from 2006 to 2010, 2011 to 2015, and 2016 till date, in NEET or All India PG, earlier there used to be 5 to 7 questions, there's a range, and in 2011 to 2015, they are somewhere between 6 to 11, and from 2016, the number of questions from anesthesia and intensive care is somewhere between 11 to 14. And in AIIMS, if you see the recent trends, the least number of questions in a single exam is 7, and the maximum questions we got is 12. And in PGIMER, out of 250 questions, in the recent trend, 8 to 14 questions you are getting from anesthesia and intensive care. And in JIPMER, if you see this number, it's a flabbergasted 8 to 17 questions, which has been coming exclusively from anesthesia and intensive care. So this is like very important, as it is approximately 5 to 6% of your entire questions are coming from anesthesia and intensive care, and the mark gained in any subject is equally important. And now I am going to say you the important topics list in the recent times, that is for the last 5 years. The criteria for any topic to made into this important topics list is at least 5 to 6 times the question should have been repeated in the last 5 to 6 years in All India PG, AIIMS, PGI, and JIPMER. And the list of the questions are pressure systems, pin index, cylinder colors, breathing circuits, CO2 absorbers in a closed system, nasal intubation, laryngeal mask airway, the fasting guidelines, also known as NPO guidelines or nil per oral guidelines, and the drugs which has to be stopped before the surgery and continued during the surgery, and bispectral index. The things which I mentioned in the red are once again which have been like more than 6 times. Here nasal intubation, laryngeal mask airway, fasting guidelines, and here bispectral index, neuromuscular monitoring, thiopentone, propofol, ketamine, etomidate. Though there are the 4 IV anesthetic drugs, all 4 have been like repeatedly asked, and MAC, mean alveolar concentration, nitrous oxide, isoflurane, sevoflurane, desflurane, and succinylcholine. Among succinylcholine, it is the contraindications of succinylcholine which is very, very, very important. And it has been asked like double-digit times, not only for the last 5 years, but since 2005, if you see the trend of the questions, this is the most repeated topic, succinylcholine, and particularly the contraindications of succinylcholine. Then atracurium, vecuronium, D-tubacurarine, phase 1 and phase 2 blocks, EMLA, eutectic mixture of local anesthesia. If you ask me 2 topics which have been like predominant importance in for the last decade, there is succinylcholine contraindications and EMLA, and bupivacaine toxicity. The spinal anesthesia, particularly they have been asking about the contraindications of spinal anesthesia, absolute contraindications and relative contraindications. PDPH, post-dural puncture headache, epidural anesthesia, which for the last 3 years the number of questions in epidural anesthesia and particularly labor analgesia is increasing, and stellate ganglion block, Beer's block are also known as intravenous regional anesthesia, and malignant hyperthermia, brain dead, IV cannulas, various sizes, various gauges of cannulas, and what is the maximum flow and what are the colors. And CPR 2015 guidelines, the American Heart Association guidelines, which has been the recent guidelines in 2015, and the weaning modes of ventilation. These are the important topics list. And in addition to this, malignant hyperthermia, and these are the topics which have been asked in the recent times, last 5 to 6 years. As we see the trend, the potential topics for the upcoming examinations, that is American Society of Anesthesiologists Physical Status Classification, ketofol, Sugama-Dex, the signs of light anesthesia and deep anesthesia, TAB block, that is transverse abdominoperineus block, caudal anesthesia, the 5H and 5T, which are the reversible causes of cardiac arrest, the brain death. These are the potential topics for upcoming exams, and also the pre-oxygenation. Pre-oxygenation is also one potential topic for the upcoming exams. So I repeat the potential topics for the upcoming exams: American Society of Anesthesiologists Physical Status Classification, ketofol, which is a combination of ketamine and propofol, Sugamadex, signs of light anesthesia and deep anesthesia, tab block, caudal anesthesia, 5H and 5T, which are the reversible causes of cardiac arrest, brain death, and pre-oxygenation. Fine. Now, the most important thing is the recent updates, whether it may be in anesthesia or in intensive care. The recent updates, the criteria here is like which have been recently added into the textbooks or the guidelines which are coming very recently. The fumarate group of non-depolarizing muscle relaxants. This fumarates, I mean fumarates are non-depolarizing muscle relaxants. And Cinera, TAC, and LET. We are going to discuss about this. These are a form of topical anesthesia. Cinera, TAC, and LET. All these three are various formulations of topical anesthesia. Surviving sepsis guidelines, which have been like recently in 2018 guidelines. American Heart Association CPR guidelines of 2015. We are going to discuss the changes from 2010 to 2015, and newer modes of ventilation. We are just going to discuss about the names, and vortex approach of emergency airway management. Vortex approach of emergency airway management. Now, over the next 15 to 20 minutes, we are going to discuss about fumarate group of non-depolarizing muscle relaxants, the various formulations of topical anesthesia, Cinera, TAC, LET, surviving sepsis guidelines, the major change which happened for the earlier guidelines and 2018 guidelines, American Heart Association CPR guidelines, the difference between 2010 and 2015, the newer modes of ventilation, the names predominantly, and the vortex approach of emergency airway management. Fine. Now first we'll go to the fumarates. Those fumarates are a group of non-depolarizing muscle relaxants. We all know the muscle relaxant. There are like depolarizing muscle relaxants, which is the prototype being succinylcholine, and non-depolarizing muscle relaxants. We know they are steroidal type of non-depolarizing muscle relaxants, where vecuronium, rocuronium came, and benzyl isoquinoline derivatives, where we see atracurium, cisatracurium, mivacurium. And this is the latest group of non-depolarizing muscle relaxants, fumarates, also in the full form being asymmetric mixed onium chlorofumarates. And the three drugs we are predominantly coming under fumarates are gantacurium, CW002, and CW011. And the mechanism of action is similar to all other non-depolarizing muscle relaxants. It competes with the acetylcholine for the acetylcholine receptor at the neuromuscular junction. And they are degraded by two chemical mechanisms, neither of which is enzymatic. There's a non-enzymatic degradation, which is obviously not Hoffman's. It has two non-enzymatic degradations. That is, one is a rapid form and another is a slower form. Slower is the ester hydrolysis, and rapid is cysteine adduction products formation. This is as simple as this gantacurium CW002 or CW011. They attach with the cysteine and they form an adduction product, which is the inactive form of the gantacurium CW002, so that it can't go and act on the acetylcholine receptor, so that it will become inactivated. This is how it gets degraded. The two forms we have to remember: rapid cysteine adduction product formation and slower ester hydrolysis. And among these three drugs, gantacurium CW002, CW011, these two we have to remember very carefully: gantacurium and CW002. Now we are going to discuss about the individual drugs. Gantacurium, it is an ultra short acting muscle relaxant. It is a rapid onset and it does not undergo Hoffman's elimination. And the two non-enzymatic mechanisms are rapid cysteine adduction products formation. One is rapid and another is slow. Rapid is cysteine adduction product formation and slow is ester hydrolysis. And we know this benzyl isoquinoline derivatives, they release histamine, predominantly is atracurium and mevacurium, but this gantacurium release histamine only in a supramaximal doses. It causes histamine release. And the way the studies are proving about gantacurium, in future we can promptly expect this gantacurium can replace the succinylcholine as an ultra-short-acting muscle relaxant and because of rapid onset. And CW002, it has an intermediate duration of action. And L-cysteine. So we know once we had given the muscle relaxant after completion of surgery or a procedure, we have to reverse the patient, for which we'll give a reversal group of drugs. If for non-depolarizing muscle relaxants of either steroidal group or benzyl isoquinoline derivatives, we usually give neostigmine or edrophonium or physostigmine. But here for fumarate group of non-depolarizing muscle relaxants, we'll administer L-cysteine. L-cysteine administration caused the reversal of fumarate group of non-depolarizing muscle relaxants. And as we are discussing about L-cysteine, I just want to add 2 to 3 more points about L-cysteine and other subjects. L-cysteine is an endogenous non-essential amino acid. It exists in 2 forms, D and L enantiomers, and this L-cysteine is used as a constituent of infant total parenteral nutrition. And I hope you remember N-acetylcysteine, which can be used as a treatment for acute acetaminophen toxicity. So the 3 take-home points I want you to remember about the fumarate group of muscle relaxants are 3 drugs, gantacurium, CW002 and CW011. Among them, again, the importance are gantacurium and CW002. Gantacurium is ultra-short-acting muscle relaxant, and CW002 is intermediate duration. 2 non-enzymatic degradations, one rapid and slow. Rapid is cysteine adduction products formation, and slower is ester hydrolysis. Gantacurium, it doesn't undergo Hoffman's elimination, rapid onset and ultra-short-acting muscle relaxant. And L-cysteine, by administration of L-cysteine, the reversal of non-depolarizing muscle relaxants through fumarate group occur. And 2 extra points, this N-acetylcysteine is used treatment for acute acetaminophen toxicity, and it is used as a constituent for infant total parenteral nutrition, and L-cysteine is a non-essential endogenous amino acid. Now we will move to the topical anesthesia, the new formulations. We all know the topical anesthesia, predominantly the questions have been asked is in EMLA, eutectic mixture of local anesthesia is a mixture of 2.5% pilocaine base and 2.5% lignocaine base, which can be used only on the intact skin. It can't be used through the cut skin. It is mainly used for pediatric IV cannulations. And now the 3 new formulations, Cinera, TAC and LET. Cinera is also known as Escaine. Cinera is also known as Escaine, and it is a formulation of lidocaine plus tetracaine. And the unique property of this Cinera is it has a heating element. Once you open the pack, this heating element will be opened, it will be activated, and with the help of oxygen, this oxygen-dependent exothermic reaction, that heat will be released, and once you apply this, it has a rapid onset, and because of this exothermic reaction, there will be vasodilation. And remember, once again, the Cinera, is a combination of lidocaine plus tetracaine, and the unique property of this is it is a heating element which activates on opening the pack, and it is an exothermic reaction which depends upon oxygen, and because of the exothermic reaction and release of heat, this causes vasodilatation and it is rapid in onset. Then we're going to discuss about another form of topical anesthesia, TAC. TAC is a combination of tetracaine, epinephrine or adrenaline, and cocaine. There's no need for you to remember about the percentages. If you can remember what is TAC, tetracaine, adrenaline and cocaine, and it comes in a liquid formulation, and it is the significance of this is this topical anesthesia TAC can be used to the cut skin. When we say about it can be used in a cut skin, it can predominantly used in pediatric emergencies, particularly for suturing the lacerations in emergencies. This is like in contrast to the EMLA, where you can't use through the broken skin. Fine. So just remember, TAC is a combination of tetracaine, adrenaline and cocaine. It's occur in liquid formulation, and it's a topical anesthesia to the cut skin, predominantly used in pediatric emergencies for suturing the lacerations. Another formulation is LET. LET is lidocaine, epinephrine and tetracaine. Again, I repeat, there's no need for you to remember the percentages. Lidocaine, epinephrine and tetracaine. And this is a cocaine-free topical anesthesia, which can again be given through the cut skin. So I again repeat 3 formulations about topical anesthesia. Cinera, combination of lidocaine, tetracaine. The peculiar thing about this is oxygen-dependent exothermic reaction, which activates on opening the pack, with the help of which the vasodilatation and rapid onset occurs. and topical anesthesia, TAC, tetracaine, epinephrine, cocaine, liquid formulation, topical anesthesia to the cut skin, predominantly used in pediatric emergencies for suturing the lacerations, and LET also helps to serve the same purpose, but it's a cocaine-free topical anesthesia, lidocaine, epinephrine, and tetracaine. Fine. Now we are going to discuss about the third topic, the surviving sepsis guidelines. Just like acute coronary syndrome or stroke, sepsis and septic shock is also a medical emergency which has to be dealt as a protocol based and in an immediate basis. And since 2005, various bundles they have been proposing the surviving sepsis guidelines, and recently 3-hour bundles, what has to be done in 3 hours and what has to be done in the 6-hour bundles were there. But this surviving sepsis guidelines of 2018 categorically mentions this, it's a 1-hour bundle. Be very clear about this 1-hour bundle. 1-hour bundle means these 5 things has to be done in very first hour itself. That is, first thing is measure the lactate level. This is a continuation of first point. Remeasure if initial lactate is more than 2 millimoles per liter, you have to repeat this lactate level after correction. Second is, before administering any antibiotics, you have to take blood for culture and you have to send for cultures, both aerobic and anaerobic. Third, immediately after taking cultures, you have to administer broad spectrum antibiotics. And fourth is rapid administration of more than 30 ml per kg crystalloids. And fifth is apply vasopressors to maintain mean arterial pressure of more than 65 mmHg in conditions of hypotension or if lactate is more than 4 millimoles per liter. I repeat, the very important point about the surviving sepsis guidelines change in 2018 is it's a 1-hour bundle and nowhere it is 3-hour and 6-hour bundles. 1-hour bundle means all this bundle, that is a 5 components, has to be done in the first hour itself. That is when you receive the patient in the ER at the emergency department, you have to do this in very first hour. That is, I repeat, measure the lactate level, and you have to remeasure if initial lactate is more than 2 millimoles per liter. After correction, you have to remeasure that. Second, you have to obtain the blood culture, both aerobic and anaerobic, prior to antibiotics. Third, you have to administer broad spectrum antibiotics. Fourth, you have to rapidly administer more than 30 ml per kg of crystalloids to the patient. And fifth is apply vasopressors to maintain mean arterial pressure of more than 65 mmHg in conditions of hypotension and if lactate is more than 4 millimoles per liter. And now if you ask me what is the vasopressor of choice, the first vasopressor of choice in surviving sepsis guidelines for septic shock is norepinephrine or noradrenaline. Noradrenaline is the vasopressor of choice for septic shock according to surviving sepsis guidelines. I hope you are clear about this surviving sepsis guidelines. There's no more 3-hour bundles and 6-hour bundles. It's very important is a 1-hour bundle. So all these 5 points, like you may get in a question like what are all the components of surviving sepsis guidelines 1-hour bundle except. So I repeat, measure lactate level, remeasure if initial lactate is more than 2 millimoles per liter, obtain blood cultures prior to antibiotics, administer broad spectrum antibiotics, rapid administration of more than 30 ml per kg of crystalloid, and apply vasopressors to maintain mean arterial pressure of more than 65 mmHg. Fine. Now we will go to the next important topic, CPR guidelines. If we see the recent guidelines by American Heart Association came in 2015 and the earlier guidelines were in 2010. So predominantly the questions will be on what are the changes when compared with from 2010 to 2015. We categorized it into changes in the CPR, changes in the BLS, that is the basic life support, and changes in the ACLS, advanced cardiac life support. And first important change in CPR, the compression rate, the rate of compressions earlier used to be 100 per minute. Now it is mentioned like 100 to 120. The upper limit has been mentioned, 100 to 120. And second, maximize the compression time. Like if we imagine a cycle of, in a cycle of 120 seconds, at least 105 seconds we have to keep compressing. That is called as chest compression fraction, CCF, and it should be at least like 87.5%. At least means like the maximum ideal thing is 87.5% and should be at least more than 60%. Remember, first important thing is compression rate should be between 100 to 120. Maximize compression time by minimizing the interruptions. And third important is deep. Like earlier they used to say it is 5 centimeters. Now it's very clearly mentioned 5 to 6 centimeters in adults. Whatever I'm discussing, this is in adults. 5 to 6 centimeters in adults. And fourth, like help of directive dispatches. That means if in the option they give like social media can be used, like they use Facebook or WhatsApp can be used for effective CPR. Yes, that's a correct option. That is, they in the 2015 guidelines they clearly mention you can use the help of social media for effective CPR to get it trained and to get the instructions from the CPR, I mean the BLS provider. And fifth is audio-visual feedback. If the provision of audio-visual feedback is there while performing a CPR, when to start and when to continue, when to go for breaths, it is advisable. So these are the 5 things, and very, very important for us is the compression rate. It should be between 100 to 120. The upper limit has been given, that is 120, and maximize compression time by minimizing the interruptions. Third, it should be between 5 to 6 centimeters, and earlier it used to be 5 centimeters depth and it's now 5 to 6 centimeters. And now, yes, you take the help of social media also for getting trained or like getting proper information while you are providing CPR. So this is very important. And then we go to the 3 top changes to the BLS. If you ask me what is one drug which you can give in a basic life support, basic life support is before the healthcare provider comes and like as a lay person, you start doing this. The drug is naloxone. The person who are in respiratory depression, if you suspect and this is gasping, you can administer naloxone either through intramuscular or intranasal, the naloxone, particularly in conditions of if you suspect opioid overdose, and even if the patient is gasping, and you can go and administer naloxone. This is the only drug which is included in basic life support 2015 guidelines. And opioid overdose education and manual spinal immobilization if you suspect spinal cord injury. And among this, the very, very important is, again, if the patient is not breathing or gasping, you can go and administer safely naloxone as a precautionary measure. Then the top 5 changes to the ACLS, that is advanced cardiac life support. Very, very, very important thing is the vasopressin is out from, vasopressin is out from the 2015 guidelines because there is no evidence that vasopressin is superior to adrenaline and we are getting extra benefits over this. So the drug which has been removed from 2010 guidelines is atropine, and from 2015 guidelines it's vasopressin. And ultrasound, we can use ultrasound in the hospital for endotracheal tube confirmation. Once in the emergency condition, if we use the endotracheal tube, we intubate the patient to confirm whether it is in place or not. Again, this is a different topic, like what are the other ways of confirmation of endotracheal tube, where the questions have been asked recently. There are 12 ways of confirmation of endotracheal tube, and 12 positive ways and 2 negative ways. That is like confirming it's not there in the esophagus. We will discuss some other time the ETT confirmation ways, and they mentioned ultrasound can be used for ETT confirmation. The categorical sign for ultrasound, if you see the through the ultrasound, for endotracheal tube confirmation whether it's the trachea or not, the sign is a bullet sign. I'm going to show you in the, see this. This is called the bullet sign. This is called the bullet sign. This is the trachea, and the artifacts which you are seeing here, it looks like a bullet. So the bullet sign in ultrasound is characteristic of the endotracheal tube confirmation, the presence in the trachea. And third, if you can't give shock, give epinephrine as soon as possible. That is, we know there are predominantly shockable rhythms and non-shockable rhythms. 2 shockable rhythms are ventricular fibrillation and pulseless ventricular tachycardia. If it is so, we can give immediately 200 joules of biphasic shock or 360 joules of monophasic shock. If not, if it is a non-shockable rhythm, the 2 non-shockable rhythms are asystole and pulseless electrical alternates. Immediately give epinephrine as soon as possible. And the 4th change is, while doing CPR, use maximum oxygen, like let it be 10 liters or 15 liters, whatever is the maximum oxygen you can provide, you provide that. And we have to remember at this point very clearly, Once there is a return of spontaneous circulation, that means the patient has been revived, decrease the amount of oxygen. This is also very important. Use maximum oxygen during CPR and decrease the amount of oxygen of return of the patient attains return of spontaneous circulation or ROSC. Then very, very important point, ECMO. ECMO is extracorporeal membrane oxygenation is a possible alternative. That is, with the help of this ECMO, the refractory cardiac arrest, which is not of, if the patient is in a reversible cardiac arrest state, this 5H and 5T, and in a refractory cardiac arrest state, like where we need some to buy time, we can take the patient to the ECMO, extracorporeal membrane oxygenation, which is particularly we use veno-arterial ECMO. With the help of this, we can maintain the circulation and ventilation for a quite amount of time. So the predominant changes in ACLS are the vasopressin is out from 2015 guidelines. Ultrasound can be used for endotracheal tube confirmation. The sign, characteristic sign is the bullet sign. And third, if you can't give shock, that is in a non-shockable rhythms of asystole and pulseless electrical alternance, give epinephrine as soon as possible and use maximum oxygen during cardiopulmonary resuscitation and bring down to the normal levels of oxygen once the patient attains return of spontaneous circulation, and ECMO is a possible alternative in refractory cause of cardiac arrest. I repeat the changes once again of CPR, BLS and ACLS. CPR, the compression rate, it is earlier it used to be 100, now it is between 100 to 120. Upper limit has been given. Second, maximize the compression time and minimize the interruption time. Third, earlier it used to be in adults 5 centimeters depth of compressions, and now it is 5 to 6 centimeters. Fourth, directive dispatches can be used through social media also. Fifth, audio-visual feedback can be taken. BLS, if the patient is not breathing or gasping, you can give naloxone. Second, opioid overdose education can be provided for the drug abusers and the close circle of opioid addicts, and manual spinal immobilization if the BLS provider feels it is injury to the spinal cord. And ACLS, the vasopressin is out. Ultrasound can be used for endotracheal tube confirmation. For non-shockable rhythms, give epinephrine as soon as possible. Use maximum oxygen during CPR and minimize it once the patient attains return of spontaneous circulation. And ECMO, extracorporeal membrane oxygenation, is a possible alternative. Fine. These are the three important things you have to remember about BLS, ACLS, and CPR. Now, I just want to put a point. The only drug which is used in BLS nowadays is naloxone. In ACLS, the two drugs are adrenaline and amiodarone. Amiodarone particularly used in the shockable rhythms cycle. Okay, fine. Now, this is the bullet sign I was showing to you. Then, newer modes of ventilation. We know there is various types of conventional or traditional modes of ventilation, which are like pressure control mode, volume control mode, SIMV, synchronized intermittent mandatory ventilation mode. And what is the role of newer modes of ventilation? The uses of that, they are more safely assist the patient. They are helpful in more effectively ventilating and oxygenating. They help in improving the patient and ventilator synchrony so that the patient should not fight with the ventilator because of the dysynchrony. And it helps in more rapid weaning from the ventilatory support. I repeat, the newer modes of ventilation helps in more safely assisting the patient and more effectively helping in ventilating and oxygenating, improving the patient and ventilator synchrony and more rapid weaning. I'm going to just describe the names of newer modes of ventilation, and we can discuss some other time. Dual control modes, VAPS, that is volume assured pressure support, PRVC, pressure regulated volume control, APRV, airway pressure release ventilation, PPS, proportional pressure support, NAVA, neurally adjusted ventilatory assist. So again, I repeat the dual control modes: VAPS, volume assured pressure support; PRVC is pressure regulated volume control; APRV is airway pressure release ventilation; PPS, proportional pressure support; NAVA, neurally adjusted ventilatory assist. So if you get the dual control modes and newer modes of ventilation as options, as a multiple choice question, to eliminate all of the above are correct about the newer modes of ventilation or not. So you have to remember this: VAPS, PRVC, APRV, PPS, and NAVA. Okay, fine. Now, vortex approach. We know, like, to maintain an airway, vortex approach is nothing but an approach used in emergency airway conditions. To maintain an airway in emergencies, there are two options for us: non-surgical airway or surgical airway. Non-surgical airway can be non-surgical airways which are helpful to maintain alveolar oxygen or through the help of face mask or through the help of laryngeal mask airway or through the endotracheal tube. If all of these three are not helpful or useful, all the three lifelines like face mask, LMA and endotracheal tube is not helping, I mean we are not unsuccessful in this, then we will land up in a condition called SICO or CICV, that is the patient can't be intubated. This is can't intubate and can't ventilate or can't oxygenate. CICV or CICO condition. That means the patient goes into hypoxia and the patient will finally go into hypoxic arrest. So remember this picture. This is called the vortex approach. You may get an image-based question. This has been like recent guidelines in 2016, and no need to remember much. But remember one thing: this, if you give this sort of a picture and ask what is this, this is a vortex approach for emergency airway management. The things which has been mentioned in the green. Green means, remember, it is a safe. If you can see, it is safe here, and again, if you can see, this part is safe. Understood? The safe. This safe zone. This whatever the blue we are seeing is it's unsafe zone. If you can see, this is like a funnel shape. As we go from above to below, it's like slanting downwards. And see here, with the help of face mask, you can bring the patient to the safe zone. With the help of laryngeal mask airway, you can bring the patient to the safe zone. Or with the help of endotracheal tube, you can bring the patient to the safe zone. If it is not possible to bring, you can use the manipulations like head and neck tilt, laryngeal pressure, and with the help of extra device or adjuncts like bougie, size and type of LMA or endotracheal tube or mask can be changed, suction or oxygen flow can be increased, and muzzle tone can be altered. All these things can be done, and despite that, if the patient won't, our aim is to bring the patient from this blue zone to the green zone where the patient is safe. That means the patient is getting oxygenated and ventilated. If we have failed in all these efforts through the either through the face mask or LMA or through the endotracheal tube, see here, with the help of face mask we can come to the safe zone, through the LMA we can come to the safe zone, or endotracheal tube we can come to the safe zone. Similarly, if we fail in all these conditions, then we can go into the another safe zone, that is surgical airway. Surgical airway is predominantly tracheostomy or cricothyrotomy. So cricothyroidotomy. So this is what we are going to do. We have to remember this green zone is, whatever the green is the safe zone, and through the help of face mask or LMA or endotracheal tube we can come to the safe zone. If not, and all the three lifelines with the help of adjuncts are lost, then we can go for the emergency surgical airway, which is again helpful, which will again push into the green zone. Okay, now the question what you can expect from this is, the three non-surgical airways are like face mask, laryngeal mask airway, endotracheal tube, you all know this. And if you get this sort of picture as image-based question, my main motto to stress upon this is a potential image-based question where you will get a similar picture and ask, what is this regarding? This is the vortex system of emergency airway management. Green is a safe zone, blue is a slanting danger zone. We have to bring the patient as soon as from this blue zone to the green zone. Fine. Now, this is about the vortex airway management. Within a minute, I'll just quickly revise what all things we discussed. Fumarates is a new group of non-depolarizing muscle relaxants. The predominant group are Guntacurium CW002 and CW011, and two non-enzymatic degradation, rapid cysteine reduction, product formation, and slower ester hydrolysis. And Guntacurium has a rapid onset and does not undergo Hoffman's elimination. This L-cysteine is used to reverse the fumarate group of non-depolarizing muscle relaxant, and it is a constituent of infant total parenteral nutrition, and N-acetylcysteine can be used for treatment for acute acetaminophen toxicity. And topical anesthesia, three things: Cinera, TAC, and LET. Cinera, the unique property is a combination of lignocaine and tetracaine, which has an oxygen-dependent exothermic reaction which activates on opening the pack, which helps in vasodilation. And TAC is a combination of tetracaine, adrenaline, and cocaine, which can be used through the cut skin. It comes in a liquid formulation. Let can also be used through cut skin, but it is a cocaine free, and it's a combination of lignocaine, epinephrine and tetracaine. And surviving sepsis guidelines, very important. It's a 1 hour bundle, and it's nowhere 3 hour or 6 hour bundles. All the things which I mentioned here has to be done in the very first hour itself. That is, measure lactate level and remeasure if initial lactate is more than 2 millimoles per liter. Obtain blood cultures, both aerobic and anaerobic, prior to antibiotics administration, and administer broad spectrum antibiotics. Rapid administration of more than 30 ml per kg of crystalloid. Apply vasopressors to maintain mean arterial pressure of more than 65 mmHg, and the inotrope or vasopressor of choice is noradrenaline. And the changes in CPR guidelines: compression rate increase it to 100 to 120, maximize the compression time, and the depth 5 to 6 centimeters. And social media can be used in direct to dispatcher state. And in BLS, when the patient is not breathing, you can administer naloxone. This is very important. And among ACLS, the very important is vasopressin is out, and ultrasound can be used for EDT confirmation. The sign is a bullet sign, and in non-shockable rhythms, give epinephrine as soon as possible. Use maximum oxygen during CPR, and decrease the oxygen support once the return of spontaneous circulation is attained. And ECMO can be used as a possible alternative. ECMO is extracorporeal membrane oxygenation, and newer modes of ventilation helps in more safely assisting the patient and more effectively ventilating and oxygenating, improving the patient and ventilator synchrony, and helps in more rapid weaning. And these are the dual control modes: VAPS, volume assured pressure support; pressure regulated volume control; airway pressure release ventilation; proportional pressure support; NAVA, neurally adjusted ventilatory assist. You have to remember this. NAVA, neurally adjusted ventilatory assist, is also a dual control mode, which is a newer mode of ventilation. And vortex approach, nothing much to remember. 3 points. It is used in this vortex approach is used in emergency airway management. To come into the safe zone, blue is a danger zone and green is a safe zone. We have 3 options to come, 3 non-surgical airways to maintain alveolar oxygen and to come into the green zone. That is face mask, laryngeal mask airway, and endotracheal tube. If we fail so, we will be slanting, and to prevent the hypoxic arrest, we can go into the emergency surgical airway, that is tracheostomy and cricothyrotomy. The center green, this is the surgical airway. This part, this green part is the emergency surgical airway. So we discussed about this 6 important updates. In the next session, we will be discussing about another important recent updates, and also the potential topics for future postgraduate medical entrance examination. So I want to stress, like, a mark gained in any subject is equally important. So give equal importance to all the subjects, and be confident. And I wish you all the very best. And now I can take all of your questions, and please put it in the comment section. Thank you guys, all the very best.